Good morning, everyone. As you enter the webinar, we're going to give people a little bit of time and we'll get started in about a minute. Good morning. I see people trickling in. We'll go ahead and get started in a minute. We'll give people just a teeny bit more time. Okay. Well, it looks as though the number has kind of stalled for a moment, so we're going to go ahead and get started. We have a jam-packed agenda today with some amazing speakers. Welcome to our webinar about navigating current issues in cancer with a focus on food and nutrition. My name is Lindsay Wyckoff, and I'm the Director of Regional Integrated Marketing for the American Cancer Society, and it's my pleasure to welcome you today. We ask that if you have multiple people listening from one line, that you please enter your names and organization in the chat so we have a record of your attendance. Attendance for everyone else will be recorded automatically. All lines will be muted during the program, and we ask that all questions be entered into the Q&A tab on your screen. We will be taking questions during our panel discussion as time permits. If we do not have time to answer your question during the panel, we will work with the presenters to have your question answered post-event. As we get started, we wanted to learn a little bit more about our audience today. Please answer the poll question on the screen and let us know what sector you represent. Okay. See people entering names in the chat. Thank you for that. All right, and it looks like we're largely looking at staff from hospital systems, so thank you for being here, community organizers, survivors, caregivers, so thank you all for being here today. Before we begin our program, we want to recognize and thank our sponsors. Without the very generous support of the Ohio State University Comprehensive Cancer Center at the James Cancer Hospital and United Healthcare, this program wouldn't be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. Now to the agenda. We are first going to kick it off with a mission story, followed by 4 presentations. And then after the presentations, the speakers will join our panel discussion. We'll end the day with information about American Cancer Society resources and a few housekeeping items. The AAFP has reviewed navigating current issues in cancer, nutrition and food, and deemed it acceptable for up to 2 enduring materials self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. The planning committee members and speakers have declared that there are no relative financial agreements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event other than that displayed on the slide. Also, please know that all of the slides will be available after the presentation, and we are recording today's event and it will be posted on YouTube. We want to begin our session today by acknowledging the individuals who are directly affected by the topic at hand. Today, we are privileged to hear from 2 of our esteemed panelists. Later in the presentation, Kathy and Melissa will share their professional insights, but like many of us, they also have personal connections to cancer. They have graciously agreed to share their stories with us today, so I'd like to welcome Kathy and Melissa. Thank you for being here.
Good morning. Thank you so much, Lindsay. We appreciate that. And I think Melissa also was on today's call. So for me, my cancer journey started back in 2013. I was a avid runner, took very good care of my health and my well-being, and just started not feeling well. The next thing I know, I went to my doctor. They immediately had me go for a mammogram because they noticed a spot. And fast forward, I was diagnosed with advanced stage metastatic breast cancer at the age of 42. It's been quite a journey. I had, of course, my ups and downs as well. But at the same time, I had a wonderful support system. And one of the things that I found that I knew that I needed to rely on was proper nutrition. I just wish back then, food is medicine would be more highlighted back then than it is today. But very glad that I am still here today and being able to share not only my experience, but also the journey that Melissa and I have continued to be on together, through a collaboration provided to us by the American Cancer Society. So again, thank you so much. And we look forward to continuing to share our journey. Melissa?
Yeah, thank you. I just want to say also thank you to everyone for being here today and for expressing an interest in food insecurity. Kathy and I talked, and we feel very fortunate that during our cancer diagnosis and treatment that we did not experience food insecurity. We had a lot of social support. We had a lot of friends and family who basically took care of us and provided meals, and it was really a blessing. It was really a wonderful thing. And so we had this conversation about how difficult it is to be going through something like that, right? To be going through cancer treatment and to have to worry about your meals, right? Like, what am I eating? When is my next meal coming? And so I feel very blessed and very fortunate to have connected with Kathy through Feed More, because if you know if I hadn't had this cancer experience, right, and it wasn't very personal to me, I wouldn't have met, I wouldn't be in this role that I'm currently in as a manager of survivorship and supportive services. I wouldn't have gotten the opportunity to work with Kathy and to see this project to fruition. So I sometimes joke around how cancer is the best, worst thing that ever happened to me.
Mhm.
And so, I appreciate this collaboration and this opportunity.
Absolutely. I feel like we hear that sentiment a lot, the best, worst thing that ever happened to me, with our survivors and patients. So thank you both for sharing your personal stories. And we look forward to hearing from you later in today's presentation. We're going to kick off today with Colleen Spies. Dr. Spies is a professor at The Ohio State University College of Medicine with appointments in related colleges, focusing her research on tailored biobehavior food as medicine interventions to address obesity-related chronic diseases. She is recognized as a fellow of the American Heart Association and the Academy of Nutrition and Dietetics. Ooh, that's a tough one. I don't know why. With numerous awards and contributions to scientific guidelines and textbooks. Dr. Spies, thank you for being with us today, and I will turn it over to you.
Thank you so much, everybody, for coming, and a special shout out to my dietitian friends on the call. It's the American Academy of Nutrition and Dietetics. It is a big one. So today I'm going to give a lot of introductory information and a bit of evidence on where we are with things. So we'll just get right into it as quickly as we can so we can get to the other panelists as well. So I think everyone on this call is an advocate for modifying lifestyle behaviors that we can in an attempt to promote healthier and optimal lifestyles, especially for, cancer prevention and for those that have cancer and for healthy survivorship and all of that. So we know environment matters. And I put up this slide because I always think of plants. I do a lot of work I have a 2 or 3 acre garden that people come out to, and you'll see many pictures about that. We'll talk about that a little bit as we go. And I just wanted to give a shout out to those that take the pictures, which are usually my students and people in my lab. So these are not professional photographers, but think about a small plant and what we need to surround that plant with. We need healthy soil microbiome. We need the plant to have an environment that supports it. We need proper nourishment and both fluids and foods for a plant to grow. So we are the same. We also need tender loving care from caregivers and those around us. So I think we'll be talking a lot about that. I also want to thank Kathy and Melissa for sharing their stories. I will say that I often hear from patients, I did everything right. I've done all the things I should do. I followed the evidence, but I still got cancer. And I just want to say, and I do say to them, that's fantastic. You did all those right things, because we know with evidence that you probably would have got cancer 10 years earlier had you not. And you probably wouldn't have done as well through treatment and had as many toxicities. So don't think of that as, I didn't need to do those things. So we'll go to the next slide and I'll show you, about all cancers combined. We think of cancers as being hereditary a lot of the times. And my family actually is impacted by a hereditary cancer prevalence syndrome called Li-Fraumeni syndrome. But really about 10%, 5 to 10% of all cancers actually are hereditary or familial. The rest of it is, as you see, 90 to 95% connected to environmental and modifiable lifestyle behaviors. And you see those on the bottom right here. And that's where we're really going to focus attention on today's call, which I think is very important. So next slide, please. And the ACS has done an amazing job, and they have guidelines, evidence-based guidelines that they put out every about 10 years. And I've been fortunate to be invited on the last 2 panels, scientific panels, to weigh the evidence and then come up with the guidelines. And you can see this is the guidelines for cancer prevention. They also have one for survivorship. You can get these online at their site, but it really advocates for promoting this evidence-based, what we know to be true. And what I love, especially about the ACS guidelines, the AICR also has guidelines, but the ACS guidelines, you can see at the bottom here, has recommendations for community action. And that may mean a lot to that section, especially for many people on the call today, because it really talks about how you and your community can advocate and advance food is medicine, and some of the things that we're now seeing in the news and we're talking about, which I will tell you, I've been around a lot of years, and I am just so thrilled that we have people outside of dietetics now talking about food and nutrition and how important it is. And ACS has always been a champion in this space, but now we have others, and many on this call, of course. So thank you for that. Next slide, please. So how are we doing? Well, this is the current lifestyles of cancer survivors. And many of you, again, know this to be true with your folks that you see in the hospital settings. So we have, over 70% of patients that are overweight and obese, and that's not just cancer survivors, but we know that this is something that drives cancer as well, in terms of body composition and obesity, in terms of excess fat distribution and the systemic inflammation and the cytokines and all the biologic responses to being overweight. We know that many people in the US do not follow the dietary guidelines. And I want to say less than, in terms of all of the US American adults, less than 7% actually adhere to the fiber guidelines even. So this is a problem. And this specifically shows you servings of fruits and vegetables, which we know that can be more cancer protective, and the role of phytochemicals that are amazing in helping our body to fight cancer and inflammation. We know people aren't moving enough, and this is based on the HHS guidelines. Sit less, move more is a great concept. We know that many people, and I'll say about supplements, and this accounts for over-the-counter supplements that are not prescribed. Certainly some cancer survivors, especially those who have gone through rigorous treatment, need some supplements, but typically those like calcium for bone health and vitamin D3 and those types of things are prescribed, or the team helps to prescribe those. But we know that many people out of active cancer treatment immediately turn towards other methods and gets on the internet and finds a bunch of supplements. That's not a great thing. And we know smoking is also a thing, much less than the general population. Next slide, please. So here we see a figure that displays the interconnections between food insecurity and cancer distress. And what we mean by cancer distress is just what it's saying. It can be displayed as anxiety, depression, trauma response. And up at the top, you see food insecurity. And then to the right of that first arrow down shows the competing demands. And then off to the right side of that, you see a lot of words on this slide. I apologize. And you all know this. The competing demands that cancer patients face in terms of prescriptions, appointments, financial distress, and all that. And what happens is then it impacts their medication use, their medical decisions, their shared decision-making, quality of life. And then in the bottom left corner, we see often cancer progression that leads to just this. So you can see it's a cyclical turn that is impacted more by food insecurity and increases the level of food insecurity in cancer patients because, you know, again, as you get into the next box, you have more healthcare expenditures, and then you have less actual household income and those types of things. So we all know this, but I just want to frame everyone again that why food insecurity, food and nutrition insecurity is so important. So next slide, please. So I'm going to go over this very quickly. This is an American Heart Association slide. And the reason I like it is because now we are turning towards more we're adopting what's called nutrition security, or food and nutrition security, not just food security. And I'll explain that more in just a second. But this slide is busy, but it shows you on the left moving from health disparities in a perfect world to health equity on the right side. And this arrow down the middle really talks about how people with food insecurity, some have food insufficiency. They're just not getting enough quantity of food, let alone not even addressing the quality. And when we help to make people, or have organizations that help to make people more food secure, we move towards what's called this nutrition security. And then these tops and bottoms talk about availability of food and access of food and utilization of food at the top. And then at the bottom, again, food insufficiency is really like hunger, a state of hunger. And then when we can move and be thinking about things like, not just do they get enough food, but is that food of good diet quality? Is it nutrition, right? Nutritious. And that's important and was missing in the food insecurity definitions in the past. And then that can help with both disease management and also disease prevention. And that's the ultimate goal. So the next slide really sums this up. This is from the USDA, and it shows you the three, I call kind of pillars of nutrition security now. And that includes food insecurity, or food security, and you can measure it. And today we'll talk a lot about food insecurity with cancer. And then also diet quality. Does the diet look like? Are these foods nutritious? Are they cancer preventive? And also health equity matters in this space. So I love this slide. Okay, next slide. And I need to mention quickly this malnutrition story, because we know that 50% of patients with cancer upon diagnosis are malnourished. I already mentioned to you all that, that we have also, in terms of the malnourishment, we have people that don't understand this definition, because you can present phenotypically with being overweight or obese, but be malnourished. Malnourished is a suboptimal state of malnutrition. So you can't look at someone and know if they're malnourished or not. So that is an important distinction. We also know, because during active cancer treatment, up to 85% in certain cancers, cancer types, are malnourished. Lung cancer, head and neck cancer, they have high rates of malnourishment. These all impact progression of treatment Malnourishment causes interruption in treatments, excess hospitalizations, decrease in quality of life. It's a cascade of events. So I just wanted to mention that there are tools, and we can talk about that on the panel later, that people can use for assessing malnutrition. Next slide, please. So this leads us to this food is medicine space. And some people don't like the terminology. I wouldn't have named it this, but it is not saying that food is trying to replace medicine. It is saying that food should be and is a partner in the treatment, prevention and treatment, and in survivorship. And that's what we like. And this is the tier from the Food is Medicine Institute that a lot of people say. I like this one because it has nutrition counseling and education spanning the entire spectrum, and others don't. And this talks about prevention to treatment as we move up. Population level is more like WIC and all those things. But as we get up here, this is where hospital systems and people produce prescriptions, medically tailored groceries and meals. We talk about now with the research, and others are talking about, like I said, which is so fantastic. Next slide, please. So I'm just going to briefly, in a minute or two, really talk about what I do. And I was funded the first time by the American Cancer Society, and have been, I do research along the cancer continuum, which you see in the arrow at the bottom. And my lab's called Hope Lab, and we do biobehavioral interventions. And next slide, we'll get to the components of many of my trials. I've been doing what's called Food is Medicine. My active ingredients always have included healthy food provision, so high diet quality, with group education taught by registered dietitians and chefs, individual behavioral counseling informed by motivational interviewing and digital tracking, trying to get to optimal nutrition and survivorship. And you can see here all the beautiful pictures. And what we show are clinical, meaningful, and significant results. Yeah, if you can show that, that would be great. That next slide. These are some of the things we measure because I do team science across the spectrum. So we do everything from quality of life and mixed methods to we're measuring microbiome and hair cortisol and metabolomics and all of the things to show what we're doing, changing dietary patterns especially for those who are food insecure and nutrition insecure and need it, actually changes the biology of patients for the better. And that's the main goal. Next slide, please. So I just want to put a call out for those of you interested in this space that the Food is Medicine Coalition, who has a great website, has recommendations that you can see. I know it's a busy slide, but these are the nutrient recommendations that they make for certain dietary, medically tailored meal, food as medicine interventions, if you actually want that. And I know a lot of dietitians are on the call, and this would be an important graphic for them, which we can share later when the slides are shared. Next slide, please. And they also have a accreditation program. For those who are looking for vendors, you can find Food is Medicine vendors in your area at this website. Thank you. They posted it in the chat. And they also have a incubator program to teach people how to become vendors in this space. And then the next slide shows that they have well, stop there, I guess, a standardization that's not on there. The accreditation also is brand new. So anyway, that's my last slide. After that, I just want to thank everybody, and we'll see you on the panel.
Thank you so much, Colleen. I think as we learn more about our cancer risk, knowing that 90 to 95% are environmental factors and behavior modification it's an incredible thing to have that control and be able to fuel our bodies in a way that's going to keep us healthy. Thank you again. We appreciate you being here, and we look forward to seeing you on the panel. Our next speaker is Julia Boker-Hawkins. Jules is the Healing Harvest Program Manager and a longtime food justice activist. In the past 10 months, Jules and their team of phenomenal volunteers have generated an 8-fold increase in the number of patients served by Healing Harvest. When not working on the program, Jules loves to read and belongs to a longstanding book club. Jules, welcome. I'll turn it over to you.
All righty. Thanks so much for having me. As Lindsay said, I'm the program manager of Healing Harvest at the Dartmouth Cancer Center. And just a disclaimer right at the beginning, I'm not a dietitian or a nurse or an MD or anything like that. This is actually my first job in healthcare, and my background is in food justice activism. So food justice is the principle, of course, that all people have the right to nutritious, equitable, preferred food. So we'll just jump right in. At Healing Harvest, we provide free, nutritious groceries critical to the health and healing of our patients as they navigate the challenges of cancer treatment. We bring together a collaborative community to ensure access to healthy food for those living with, through, and beyond cancer. Next slide, please. So the background of this program is really interesting. I was brought in just about a year ago today, but the roots of the program go back a few more years than that. So the story begins in 2021 when the Dartmouth Cancer Center started implementing the social determinants of health screening, which I'm sure many of you guys are familiar with. And that was the first time at our cancer center that we had real evidence of how prevalent food insecurity is in the patient population. And it became clear that we needed to do something about it. So it began actually with one social worker named Catherine Reed, who started serving her thoracic oncology patients out of the filing cabinet drawer of her desk. She would go to BJ's, buy canned goods, pasta, that kind of stuff, and just give it out to people on sort of an informal basis when she identified them as needing food support. So from that work, it was clear that there was a much larger need. And in February 2022, they started a pilot project. So that was with one registered dietitian working 2 days a week out of, as you can see in this photo, the back half of a copy room in radiation oncology. So it was a pretty scrappy program at that point in time. This is what it looked like when I was brought on last summer. And they filled 175 orders in that period. So a really great increase and a good start to the program, which demonstrated, as we expected, that the need is significantly greater than that. So starting in July 2024, I was brought on as the first full-time program manager. We had a significant annual budget, which is funds raised by the Proudy, which is like the philanthropic event of the year for our cancer center. And just last year, actually, since the fiscal year wrapped a couple days ago, I know that we served 3,475 orders to 681 distinct patients. And this photo is of two of my volunteers working in our new space, which was custom built for the purpose. So next slide. This is a portion of the presentation where you guys are allowed to take out your phones. So if you are interested in taking a look at our online ordering platform, you can scan the QR code to the left there, or go to toasttab.com/healingharvest. So one of the first things that we did was create an online ordering platform using Toast, which many of you are probably familiar with as like the primary takeout ordering platform for restaurants. So it took a little while to figure out what kind of platform would make sense for us to be able to take grocery orders from cancer patients. And of course, working in a hospital with patient data, there's all sorts of like cybersecurity, HIPAA concerns. So that took us a while to iron out, but it's really cool because the Toast system allows patients to place totally customizable orders and for us to update the inventory on a daily basis as we get new food in. So that was a big accomplishment. We also rebranded. When I was hired, the program was called the Dartmouth Cancer Center Food Pantry. And we found quickly that upon calling patients who had screened positive for food insecurity through the social determinants of health, I would call them and say, you know, this is Jules from the Dartmouth Cancer Center Food Pantry. You're eligible for our program and we would love to help you out. And what we heard the vast majority of the time was, oh, I don't need a food pantry, or I don't want to take from other people who need it more. And those, of course, are patients who were already food insecure prior to cancer treatment and were at a really high risk of their situation becoming increasingly dire during treatment. So we renamed it to Healing Harvest to emphasize the food as medicine concept. We just recently joined the Food as Medicine Coalition as a medically tailored grocery project. But we have always felt that it's really important to emphasize that Healing Harvest is a part of the healthcare that patients are entitled to when they're receiving care at the Dartmouth Cancer Center, and that it's a really friendly, abundant program without the stigma associated, unfortunately, with the concept of a food pantry. So the rebrand brought us a lot of new folks. We recruited about 20 new volunteers, many of whom are cancer survivors themselves, which is really awesome. Obviously, they're super passionate about the work, and it means so much to them to be able to help others. And we opened the custom-built program space, which you guys saw on the last slide, and improved our supply chain logistics. I will say, we'll probably get into this in the panel, that's by far the most challenging part of this type of work, is running basically a grocery store inside of a hospital. Like, the logistics of that can be quite a challenge. But we exceeded our goal. You can see on the left here, that's me posing with a little cake because we exceeded our goal of growing the program more than 10 times in a single year. So the month that I was hired, last July, we served 66 orders, and I believe it was in May, we exceeded 660 just in that month. So it's been a whirlwind. Next slide, please. And I would say the most common question that I get from people about this program, because it is so unique in the cancer space, is like, how do you do it? Like, just how? I'm sure that a lot of you who've worked in healthcare much longer than I have are very familiar with the bureaucracy and the red tape and just the challenge of getting anything significant and perhaps different than the status quo done in the context of healthcare. So I wanted to use our mural as sort of a visual analogy for our theory of change. And this mural, so that's the outside of our new program space that was custom built for us. The concept was actually created by one of my colleagues who runs our complementary care program, Heather Allen. So they do a lot of really great survivorship programs, support groups, massage, Reiki, therapeutic harp. And she had the awesome idea of doing a mural utilizing the awareness and survivorship colors for different kinds of cancer. So, like, the blueberries are for colon cancer, the strawberries are for breast cancer, the blue Hubbard squashes are for prostate cancer. It was hard to find a light blue vegetable, but we did pull it off. And so she, just one person having a really great idea, kicked off this whole thing. And I think that that can often be the case with food interventions. Like, it's just one person thinking outside of the box can get something really cool started. So the next photo on the right is one of our Schweitzer Fellows, so a medical student at Dartmouth, Corbin Dameron, helping me do the outline of this mural. And it's dark in this photo because it was the middle of the night. We, I think, stayed until like 1 a.m. the night that we installed this mural outline. And I think that emphasizes the second phase of a project, which is, you know, one person has a great idea, and then a small group of people are going to work really hard to get it off the ground. So huge shout out to Corbin. She is a really inspiring person and a great artist who helped me with this installation. And then phase 3, bringing it all together. I think community buy-in is essential for anything like this to work at a hospital. So we intentionally designed the mural as sort of a paint by numbers. So Heather came up with a color scheme, Corbin helped me do the outline, and then we had an event, an installation day, where we invited providers, patients, volunteers, care partners, really anyone who was at the cancer center that day was welcome to come down and help. And we had about 40 or 50 people who came down to help us paint the mural, which was really fun and special. We had a team of surgeons at one point come down from the OR, like scrubbed up. And as you can imagine, they are really excellent painters. They stayed right inside the lines. So it was cool to see everybody come together and work on that. And it's really meaningful to people, I think, to have a feeling of ownership and a stake in a project like this. One of our nurses in radiation oncology who painted a carrot will use that carrot as like a way to bring people who are hesitant to the program. She'll tell them about Healing Harvest, and then if they, you know, seem hesitant or aren't sure if they really want to come over and meet us, she'll say, and I helped paint the mural, so come over and see the carrot that I painted. And that's a great way to get people into the space, talking with us and realizing that it's, you know, a friendly program, and that we're happy to help them purely because they are a cancer patient and they're eligible for it. So The final mural, as you can see here, is really colorful, really laden with meaning, and was only possible because of the help of so many people who all put in just a little bit of effort to make this project come to life. And it's really part of the ethos of the Healing Harvest rebrand as well, that we have a super identifiable space, which is a harsh contrast to our old space in the back half of a copy room that nobody could find. And just having something that is colorful, beautiful, welcoming, cheerful, I think really lifts the vibe in our basement radiation oncology department and encourages patients to utilize the service for sure. So I believe that's all that I had. If you guys have any questions, we'll get to that in the panel. And thank you for your time.
Thank you so much, Jules. It's very clear that the intentionality and the community building that you are leading with is making a difference. I mean, to have surgeons come down and help painting murals, that is truly bringing a community together. So thank you for that work that you're doing. Our next presentation, we will bring back Kathy Grime and Melissa Wanzer. Kathy is an accomplished Chief Programs Officer at Feedmore, Western New York, leading the Strategic Planning and Operations Management team. She has significantly enhanced program efficiency and stakeholder engagement through her decades-long experience in the local food industry, including her role as merchandising and training specialist as a merchandising and training specialist for 20 years at a leading regional grocery store chain. She has leveraged exceptional communication and leadership skills to foster team collaboration and drive organizational development with a proven track record in crisis management and profitability improvement, demonstrating a commitment to excellence and innovation. Melissa is a manager of survivorship and supportive services at Great Lakes Integrated Network, where she oversees programs that educate and support oncology patients and caregivers. She is also professor emerita at Canisius University with research interests in patient-created centered communication, humor and coping, and cancer survivorship. She holds a Master of Arts in Communication from Syracuse University and in EDD in Communication and Instruction from West Virginia University. Welcome. I'll turn it over to you two.
Thank you. Next slide. So we want to get started by giving you a little bit of project background. So as Lindsay stated, I'm the manager of survivorship and supportive services at Glenn. And I also want to make the same disclaimer that I do not have a background in healthcare, as you heard from my bio, nor am I a nutrition expert. And that is where Kathy comes in 100%. So my team at Glenn, we are the Oncology Supportive Service team, and it includes 5 nurse navigators, a social worker, a care navigator, a dietitian, and several other individuals. And we provide oncology supportive services for a number of health organizations. We're a community-based cancer center, so we work with General Physicians PC, Kaleida Health, and as I said, a number of other organizations. And the story behind this project is that many of the providers, a number of the providers at our medical oncology offices, our medical oncology sites, were talking about and sharing stories of patients struggling with food insecurity, that they were coming to their appointments, they hadn't eaten, or they were, again, struggling to find food to feed their families and themselves. And so the staff really dug in and started purchasing food for the patients. And they would make sure, for example, that patients ate before they went upstairs for their infusion. And they described a problem, kind of several different things that they observed, which was food insecurity, obviously poor nutrition. But another thing that we don't always talk about too with cancer patients is fatigue. And, as someone who went through treatment, I know that chronic fatigue is real. And sometimes you don't even feel like, going to the grocery store, you can't even decide what to eat. So fatigue was an issue. The staff started purchasing, very similar to Jules' story. You know, they had drawers, they started a drawer full of food, and they started purchasing food for the patients. And I quickly realized that this was not sustainable and we needed help. So next slide.
So that's where kind of Melissa and I kind of got together. And, you know, as far as Feed More goes and some of the statistics that we have. So Feed More itself is a food bank as well as a Meals on Wheels program that merged back in 2019. So we have many different programs that fall under our umbrella. When you're looking at the rate of food insecurity in Western New York, we are at 12.7%. And then we feel as though that number, of course, you know, with the State of the Union today, could, of course, be on the rise. We also know that food insecurity is higher among the most vulnerable populations, including those with a cancer diagnosis. As I mentioned, Feed More Western New York is the largest hunger relief provider in Western New York. We saw a 16% increase in the need for services in 2024. We served over 100, almost nearly 166,000 individuals, and we have not seen this number since the peak of the COVID-19 pandemic.
So the way that Kathy and I were brought together is through an Addressing Barriers to Care grant. So I learned about this grant through our ACS contact. Shared the information. Again, this is a pilot grant. This is very much a pilot program. I would say we are, you know, looking at the phases of the last program. We are in phase 2 for sure of comparing to Jules' program at Dartmouth. And so we applied for Addressing Barriers to Care grant, and we focused in that grant proposal, we focused on providing kind of three resources for patients. And because we had started, I would say, you know, at a very minimal level, we had started with, you know, a small pantry. Once we realized that patients needed food, we had a small pantry also at our practice. So I can relate to the last example as well. In our medical oncology practice, in our vault area where they store a lot of medical supplies. We started a food pantry there, so that was going to be part of it. And then I'll let Kathy describe the other 2 elements of the grant proposal.
So when Melissa kind of expressed, you know, the needs, you know, of the patients that her institution, which is phenomenal, by the way, were seeing, we knew that, of course, we had the ability to be able to provide food. So we currently right now have a grocery list of items that Melissa can order. And those are items that are shelf-stable food that are, of course, secured in the food pantry. We also, through our Meals on Wheels work, provide medically tailored meals to individuals that are looking for more of a home delivered meal program. We have 6 different medically tailored meals. So we know if somebody, of course, is going through a cancer diagnosis, they might have to be worrying about, you know, the amount of acid that they're, you know, consuming. So they might want to stay away from certain sauces. So they might need to be on a bland diet. We know individuals, of course, that are going through a cancer diagnosis might also be having going under dialysis. We might need to put them on a renal diet. So we're able to provide 7 days a week of home delivered meals where actually our paid staff or our wonderful volunteers go out every day in our community and not only deliver the meal, but they also do a wellness check also. We're also very fortunate here at Feed More that we have a staff of 7 registered dietitians as well as 6 social workers that can provide some type of nutrition counseling, education, medical nutrition therapy, also help anyone that is in need of SNAP outreach and benefits. We have 3 individuals that are on staff that can help understand the process of that. So you know, again, us being able to partner together, again, we're able to identify the services that these clients need, and hopefully, again, put them more at ease.
So I just want to show kind of the workflow of what this looks like from the patient, identifying the patient's needs. So we start with the patient. The patient will be connected with either a nurse navigator, a social worker, or they will be identified as having some type of food insecurity or food need, also from the team. So one of the 5 nurse navigators will reach out, or again, the social worker, or again, a practitioner or APP will say, this person is experiencing, food insecurity. They connect directly to me. They message me through our EHR. I get a triage, a to-do, a referral. And then from that point, I work with either sending them I connect with the patient, and I ask them if they're interested in the home delivered meals. I send a referral over to the social worker. A social worker then arranges that delivery with the patient, and the patient receives home delivered meals for 8 weeks, which is an absolutely wonderful service. The other service, obviously, through the grant that we were awarded is through our food pantry. So same kind of thing, a navigator, social worker, one of the practitioners will message me, and they have identified food insecurity or chronic fatigue, and they want access to the food pantry. From there, they will send me a message and say, okay, can you connect with this person? We put in we have one of the APPs who supports us, who puts in a to-do in the EHR to make sure that we know that this person will regularly receive a food pantry bag at their appointment, right? At their appointment at medical oncology or infusion. And so then how we prep those bags is we have a calendar for each month. We get these bags of non-perishable food prepared, and then they are distributed through our PSRs at the front desk. So the PSRs will say, we'll identify patient Mr. Smith, don't forget your food. They'll take it out to their car or bring it up to them at infusion. It's been highly successful. I will say it does take an army. It does take a village to pull this off. Next slide. So some of the most significant project outcomes, this project has been incredibly successful. We've been able to provide service to 283 patients. A lot of those patients, there's overlap. They receive both the food pantry and the home delivered meals. The reach is extensive. These patients are coming from 82 different zip codes in Buffalo and surrounding areas. We also have patients who travel significantly. So they're coming an hour or 2 away. They're experiencing significant financial toxicity, food insecurity. So those patients are, we identify those as well. A couple of quick things I'll just say as far as the benefits: consistent food. That 8 weeks of food, the patients talk about how important that is. We also see that patients gain weight. We've had the providers comment that a number of patients have gained weight, and so therefore they can continue their treatment. They're eligible for surgery. We also know that it has helped them reduce the financial burden. They talk about how this helps. Their bills have gone up. And I think another thing important, kind of intangible, is the connection with the team. Then next slide. Kathy.
Yeah, so really the lesson learned, the clear impact of the health outcomes, the well-being and quality of life of patients. Again, that's so important. The other thing that I want to just kind of talk about it also, again, is helping with the caregiver. I think sometimes, Melissa and I know firsthand as a patient, we're being poked and prodded, all the time. But sometimes, again, the caregiver feels a little bit lost. So knowing that somebody's loved one is being taken care of, they're getting the meals, it's putting less burden also on the caregiver to always, of course, making sure that someone's getting, the meals. But also what we're offering is making sure they're on the appropriate diet. Because of course it all goes back to proper nutrition as well. So again, we feel that the need to continue these services are so critical. And again, as we are just very fortunate and blessed that we've been given an opportunity to partner. So thank you.
Thank you, Kathy and Melissa. I loved hearing about the program. I think being able to deliver meals and tracking nutrition, you're meeting people where they are as they're in such a vulnerable time where nutrition and food is so important. So thank you for that important work, and thank you for sharing with us today. Our final presentation, we will hear from Kristen Sullivan. Kristen is the Director of Cancer Wellness at the American Cancer Society, focusing on reducing cancer risk and improving outcomes for survivors through nutrition and physical activity. She has held various positions within ACS and previously served as a Health Communications Fellow at the Centers for Disease Control and Prevention. Ms. Sullivan holds a bachelor's degree in molecular biology from Lehigh University and a master's degree in nutrition and public health from Tufts University. Kristen, I'll turn it over to you.
Great, thanks so much. I'm so excited to be here today and to hear all these amazing presentations. Today, I'm going to talk a little bit about a pilot that we did through our ACS Hope Lodges to screen for food and nutrition insecurity among the guests that are staying at Hope Lodge. Next slide. So for those who aren't familiar with ACS Hope Lodge, these are lodges that offer a free place to stay for cancer patients and their caregivers while they're going through treatment, if that treatment is a certain distance from their home. So these are beautiful, amazing facilities where the patient and caregiver have their own room, but there are also common spaces, including a full kitchen at all of our Hope Lodges. So people have access to refrigerators, storage cabinets, full cooking equipment. So it is meant to be kind of a home away from home. Anecdotally, over the years, we've heard from our Hope Lodge staff that, unsurprisingly, guests who are staying there are often struggling with financial hardship, which many people with a cancer diagnosis do. And that has included kind of lack of access or resources for healthy foods. We often have kind of programming at the Hope Lodge where volunteer groups will come in and cook a group dinner. Or some Hope Lodges have had some programs where local grocery stores will donate some food items, and that's always very well appreciated. But we never really had a sense of like systematically what the real need was among our Hope Lodge guests. We know that food insecurity tends to be an issue and higher among people with a cancer diagnosis than the general public. A recent review of the literature showed a wide range of food insecurity among people with cancer, anywhere from 4% in certain populations up to 86%. But it tends to be higher than the kind of 13.5% food insecurity rate in the US overall in 2023. So the aim of this project was really to, for the first time, systematically screen our guests for food and nutrition insecurity to document the prevalence of that issue. And then kind of a secondary aim was to kind of figure out the best way to meet that need. Next slide. So beginning in April 2024, we identified 10 Hope Lodges that we asked all guests that were checking into those lodges to complete a food and nutrition insecurity screener. Guests who screened positive for either one of those conditions were provided a $100 Instacart Fresh Funds voucher. So this is basically a grocery delivery service. Upon checkout, the guests who received the voucher were then asked to complete a satisfaction survey. I will say I present some of the results of that survey in this, but our response rate was very low. So it's more, those data are kind of more of a guide for us. They probably are not representative of the entire population just because our response rate is low, which isn't surprising. We do struggle with this population to get people to kind of communicate with us digitally through email or, through an online survey. So just kind of a caveat that some of those results are based on small numbers. To screen guests, we used two tools. One is the Hunger Vital Sign, which uses 2 questions to screen for food insecurity. So this really kind of gets at financial hardship and the ability to afford food. And then we also screen for nutrition insecurity using a 1-item screener that was developed by the Center for Nutrition and Health Impact. And this gets a little bit more at the kind of diet quality and people's ability to eat a healthy diet. Next slide. So just an overview, we had 10 participating Hope Lodges. Between April of 2024 and June of this year, we screened 1,369 guests. Of that number, 570 was screened, had a positive screening and were eligible for the Instacart Fresh Funds voucher. So that is about a 42% positive screening rate for food and or nutrition insecurity among our Hope Lodge guests, which is, a pretty substantial need. Next slide. So looking at how this breaks down, the majority of people were screening positive for food insecurity with and without nutrition insecurity. So that's about 35.1%. Another approximately 7% were screening positive just on nutrition insecurity. So the financial need wasn't what was having them screen positive, but it was more the diet quality need. Looking at demographics, age was definitely a predictor. So people who were under the age of 65 were significantly more likely to screen positive. And this is consistent with the literature that shows that a cancer diagnosis of people under the age of 65 does tend to result in more kind of health-related social needs, including food insecurity. People with a race other than white were more likely to screen positive, as well as people identified as Hispanic Latino. And again, this is consistent with what we see with food insecurity kind of in the US population as a whole. Next slide. Satisfaction with the program. And again, these results should be taken with a little bit of a grain of salt. We only had 69 people responding to this survey of the 570 who were eligible. But overall, the people who responded were satisfied with the program. They were satisfied with using the Fresh Funds program and the quality of groceries they received. Next slide. The vast majority of guests who responded to the survey reported kind of positive outcomes or, positive experiences. So we had hypothesized that there were a number of reasons that people would struggle with nutrition during this time, some of them being financial, but others are like stress related and that kind of thing. So we did see that most people who responded said that the funds helped to reduce their overall level of stress. It helped them be able to afford their groceries. It helped them eat a healthier diet quality, including more fruits and vegetables, and helped them to be able to kind of like keep up their strength and tolerate their treatment while they were in treatment. Next slide. We tried to get at, why people might not have liked the Instacart program. And again, these were people who responded to the survey. We're hypothesizing that people who responded probably had a more positive experience. So again, there were low levels of discontent, but people did say that they didn't love shopping online for groceries. They want to pick out their own groceries in a store. Some people said it was too time consuming. And then there was definitely a small number of people who found, registration with the Instacart program a little bit difficult. Next slide. So some of the challenges that we saw was that the screening and enrollment for this program was manual, which was a little bit time and resource intensive for our Hope Lodge staff. Like our Hope Lodge staff are managing these entire programs. This is just one small thing that we're asking them to do. Some of the guests ran into problems redeeming their codes on the Fresh Fund site. It was not like the most user-friendly program. We had a low response rate on the follow-up survey, so we're trying to figure out how to kind of get people to do the survey even before they leave the lodge, or trying to figure out a way to kind of increase the rigor of those data that we're collecting. We had more people than we expected that were kind of waiting to use the voucher until they went home. So didn't really have experience with the program at the time they were asked to fill out the follow-up survey. And then there were some barriers that were specific to the Instacart platform. So one of them is that in order to order groceries, even with a voucher, you have to put in your own form of payment as a backup. And that was a hardship for some of our guests. And especially if they were using a debit card, there's often like a hold placed on their funds, which can be an issue. For guests who didn't have a backup form of payment, we wanted to make sure that they were able to benefit from the program. So we had our Hope Lodge staff use an American Cancer Society purchasing card as that backup. So that was just more kind of time and effort for our staff. And then we got some feedback that the fees, delivery fees and other fees from Instacart kind of cut into the amount of money that they had to actually spend on food. Next slide. So this is just some guest feedback that we collected, some qualitative feedback. People really talked about this is, it helps financially. Every little bit helps when you're, have a cancer diagnosis and are having financial hardship. Some people talked about, they like the convenience of not having to leave the lodge. So these lodges tend to be situated near major cancer centers. So for a lot of people, it's a more urban environment and an unfamiliar environment that they're a little bit nervous about kind of venturing out in their car for groceries. So having groceries delivered to them was convenient. And then just kind of relieving the stress overall. And we did have a couple people comment about their caregiver and how this was helpful for their caregiver to not have to think about, in addition to kind of being at the hospital all day for treatment and appointments, then not having to think about what to do for food after that. And then there were some challenges that came up in those comments as well. Unexpected charges on their card, figuring out how to connect to the store that they wanted, that kind of thing. So ultimately, the conclusion is that we really were looking to kind of systematically assess food insecurity in our Hope Lodge guests. We saw that the need is in fact substantial. And we continue to think about ways to meet this need in a way that's kind of acceptable to our guests while they're staying at Hope Lodge. And I think that's it. I have some additional slides that will be we don't have to go through these, but that will be in the deck that you get sent if you want to kind of delve a little bit deeper into that.
Thank you so much, Kristen. If you don't know much about our Hope Lodge program, it's already removing an access to care barrier with free lodging, but to add this on for our patients is so incredible. So thank you for sharing that. I'm excited to see where these programs go from here. It is my pleasure to now introduce you to our panel moderator, Marianella Napolitano. Originally from Ecuador, Marianella moved to the U.S. for her undergraduate degree in Information Management System and Nursing, later pursuing an MBA in Healthcare Administration. With over 15 years of leadership experience in healthcare, she has supported providers serving vulnerable populations and implemented population health strategies. As Director of Population Health at United Healthcare, she oversees the strategy, implementation, and evaluation of the Population Health Management Program for the Ohio Health Plan. Welcome, Marianella. I'll turn it over to you.
Great. Hopefully you can hear me okay. Thank you for the introduction, and thank you really for the opportunity to moderate this panel. Not only access to food remains a pressing challenge, but it is also a priority here for us at United Healthcare Community and State Plan of Ohio. So I'm really looking forward to the conversation and continue to learn from our panelists. I know that there's probably a lot of questions specifically around what we can do to help address some of these issues. But I'm actually going to start primarily talking a little bit about what cancer survivors are experiencing as it relates to food before we go on to the operational aspects. So let me start with you, Colleen. From your perspective, what are some of the most common nutritional challenges faced by cancer survivors?
Yeah, thank you. And I really loved hearing everyone's presentations and the amazing work folks are doing out there. So that's just so heartwarming. So, nutrition is up there for sure. We've heard a lot about it today and the people who are meeting those needs. There are different nutrition challenges along the continuum of cancer. So for instance, prevention, there's certain nutrition things, again, I'm going to refer to the ACS guidelines for how to try to prevent cancer in the first place. Most of what we're talking about today are those who have been diagnosed with cancer. And we know that modifying lifestyle behaviors, including nutrition, can prevent secondary cancers, can, again, increase your response to treatment, decrease toxicities, especially for nutrition and folks going through cancer and even after cancer and adjuvant therapies. There's something called nutrition impact symptoms. And this is very important because these are the symptoms that And we heard about fatigue today. And we've heard about there's things like anorexia and constipation. You think about what we know, chemotherapy or immunotherapies and that kind of thing. People have responses to their cancer treatments that are nutrition related. And we can mitigate those and help people continue through their prescribed cancer treatment. And when there's interruptions in treatment, or when people have to sit back and they miss 2 or 3 of their therapies, we know that increases their long-term their mortality. So we want to keep people adhering to those, but part of the problem is the lack of reimbursement and funding for those who can help them with nutrition, which is our oncology dietitians or those that are trained. The current ratio, and we have a publication, I can put that in the chat in a bit, the link to that, is currently in outpatient cancer centers across the country where over 90% of cancer patients are treated. The ratio is 1 registered dietitian to every 2,300 cancer patients. And that is just unacceptable. And if we could get the reimbursement, it's not a lack of dietitians, it's a lack of reimbursement from CMS for dietitians. Then I will tell you, those dietitians could assist all of us to help promote these wonderful programs that you're hearing about today and serve as a segue and a partner in doing that. And I think that is one of the major things. So I'll stop there and let other folks weigh in. But these are the types of things we're facing that we're trying to piecemeal a lot together. And then quickly, I'll just say, in terms of post-active treatment, we know that nutrition is so critically important, and folks want to know what to do, and they are asking for nutrition services, but if they just can't pay out of pocket for that. So that's part of, I would say, one of the biggest challenges we're facing. And Kristen and I are working on this very hard in some of our publications and other things that we're doing. So hopefully we'll be able to get this reimbursement thing worked out. Thank you.
Thanks, Colleen, for that. I think we can all agree that nutrition is extremely important. And I think that's the current landscape, I think, presents a lot of challenges, but also a lot of opportunities. And I was excited about today's topic because I think that there's an opportunity for us to leverage existing mechanisms to try to address some of those challenges as it relates to reimbursement and sustainability. But let me ask you, Melissa, what are your thoughts? What are from your perspective, right? What are you seeing as it relates to nutritional challenges and the individuals that you interact with?
So, I absolutely agree with everything Colleen said, that, access to a nutritionist, I mean, that has been a barrier, right? And that number is staggering. I wrote that down, 1 to 2,300 patients. I mean, we have a nutritionist, right? We have a dietitian on staff, but she is overwhelmed with the most pressing cases, right? And so, to your point, like, it would be ideal if everyone could see, right? If everyone could see the nutritionist and talk about, about the dietitian, talk about balanced diet and what to eat post-active treatment. I look at this another way too, is that, fatigue. And I talk to a lot of patients who are they're exhausted. And I think of a patient specifically who said, I can't even get out of my chair to walk to my kitchen. And so that's where I think these home delivered meals are incredible, because the patients say this saved me. I had one patient who said, I have not eaten this well in years, and she cried. And that idea of fatigue and not decision paralysis, right? I mean, chemo brain, all those things are real. And Kathy and I talk about that. We went through these things, and so how can we help patients when they're struggling with chronic fatigue, or they're alone, their spouse has passed and that spouse cooked for them and did all the grocery shopping, and now they don't know how to care for themselves. So I think it's a very complex problem, believe me, a very complex problem. And I am not, claiming to know all the answers, but I think that it is, there are solutions, and I think there are opportunities there are opportunities, and our partnership with Feed More has been a great example of that.
Thanks, Melissa, for that. And I love the ending on positivity to your statement, right? Like there's opportunities, and maybe perhaps that is a good segue into talking a little bit about what the opportunities are out there. So I know from my experience, right, representing Medicaid payers here in the state of Ohio, we many times have a lot of nutritional programs available that are underutilized. And this question is really for you, Jules. I think you talk about the rebranding and how you really emphasize more of the healing aspects of food. So can you tell us a little bit more about what that really entail? Do you have to screen differently for food access? Because that's something that I hear commonly, right? Like we ask, but then when we offer, nobody wants to access those resources.
Yeah, that's a great question. I've realized, unfortunately, that screening cancer patients for food insecurity is diabolically complicated. We administer a screener with, it's like sort of a meta screener. So it's the hunger vital sign, the malnutrition screening test, which our dietitians also use, and a USDA food security inventory, which was actually not designed for surveying, but it's more useful for descriptive purposes because the hunger vital sign, which is what most clinicians use, just yields a binary food secure or food insecure answer, whereas the USDA recognizes 4 degrees of food insecurity. So high food security being you have no concerns about access to food. Marginal food security, which is extremely common among cancer patients, is you are not lacking food yet, but you are concerned about that being an issue for you in the future. And that is really where we see a lot of cancer patients experiencing the negative mental health effects of all of this through the course of treatment, because even if they're not yet in a more dire food security situation, worrying about it obviously takes such a huge toll on your physical and mental health. So the level below that is low food security, which is when you are basically meeting your caloric needs, but you're not necessarily getting the quality of foods, the variety of foods, all of those things that we think about when we talk about nutrition security. And then the most serious situation is very low food security, which is where patients are actually reducing the amount of food that they eat because they don't have enough. So I think honestly describing the problem as food insecurity as opposed to hunger, which is how a lot of us heard about it growing up, is a huge step in the right direction because not all patients who are food insecure are literally hungry at any minute in time. And using these more advanced surveying tools and descriptive methodologies, I think, can have a big impact. But our fourth tool, which I think is potentially promising, although it's really experimental and sort of in beta testing right now, we call the Social Obstacles to Food Security Inventory. So it was developed in conjunction with our dietitians and social workers, and we screen people essentially for 10 challenges that are super common among cancer patients. So it's a 10-question inventory, and it touches on things like, can you get to the grocery store? Transportation issues are huge in our really rural community in New Hampshire. Do you have the time to cook, which is particularly challenging for younger patients who are working or have caregiving responsibilities? Does your physical health enable you to cook? Can you hold a knife? Can you stand in the kitchen? Your mental health, do you feel motivated? Do you struggle with brain fog that makes it impossible to put together a grocery list and figure out what's for dinner? And interestingly, when we look at these sort of 10 markers of potential food insecurity, the most common ones are issues that are not super prevalent in the general public discussion about food insecurity. So the number one concern for our patients is mental health, which I was not anticipating. It's fascinating to me that people who are cancer patients, and the majority of our patients are in the later stages of disease progression, so pretty seriously ill by medical standards, they will rate their mental health worse than their physical health and more of an obstacle to their food security. And then the other one, which I will admit I never ever thought about prior to working in cancer, is immunocompromised status. A lot of our patients have either been told by providers or just have a general sense that like they are not to go to the grocery store, they can't mingle with the general public, and that those kinds of everyday food procurement tasks are really, really dangerous for them. So yeah, long story short, it's hard to measure. We're trying a whole bunch of different things and seeing what sticks. But it's a challenge and it's an ongoing developing field of research.
Thanks for that, Jules. Definitely right. Like there's a lot of tools, resources. It's a complex topic. I am curious, and maybe this is a question perhaps for you, Kristen, and or you, Kathy, or Melissa. Sometimes I feel that we screen for a lot of things, right? I think, Jules, you talk about like, the 10 different questions, and depending on what you answer, right? Like you fall into what category or not. What's been your experience so far, specifically around using these type of screenings, right? Like, are people open and willing to provide this information? Perhaps you can, Kristen, Kathy, or Melissa can speak a little bit about that.
Yeah, I mean, I think Joel's made a great point. I think we use Hunger Vital Signs and many others because it's really simple. It's short, but it's probably not getting at the full story. So the discussion around trying to assess nutrition insecurity a little bit more rigorously, I think, is really important. But yes, I think, in our project with Hope Lodge, but I think this is reflected in the literature as well, is that it's a sensitive topic. So there are ways that we try, and I don't know, I'm sure it's still not perfect, but making sure that when we ask people to do the screener, we give them an iPad for them to kind of fill out some demographic, a very short survey. We're not asking them verbally, so they don't have to kind of be embarrassed to say it out loud. I do think, and we've heard before that people, when we offer them the program, say like, oh, no, I don't need that. Like there are people who are more in need than I am. Like that's not me. So I think there is a challenge with getting people to kind of accept the service and I think, I think Jules in her presentation did a great job of talking about how to kind of change some of the language and the framing, to not make it seem like they're accepting charity, but that it's just another one of like the programs that's available to them through the American Cancer Society or through their cancer center or whatever. But yeah, I think it's definitely a challenge. We do have people who screen positive and kind of decline whatever, we're trying to give them for that. And I think, especially with cancer, I mean, it's more than just a financial hardship, right? For many people, it's a physical hardship. It's a stress-related hardship. It's a hardship on their caregiver who may not normally be the one to be doing the cooking or the shopping in their household, and now are kind of forced into that role. So yeah, I think there's still a lot to learn in this area for sure.
Thanks for that, Kristen. Kathy, maybe perhaps you can tell us a little bit about like how can we include survivor voices in program design and evaluation? I think that that's an important component in all of these, right?
Absolutely. And I think one of the things that when we are doing a clinical assessment of an individual that is in need of our service, it's really kind of designing almost like a meal plan for them, providing that nutrition counseling. So once somebody's been identified, let's say is having issues with food security, is then kind of almost educating them on how to get that proper nutrition. Whether it's dietary modifications, trying to, let's say, eat smaller meals more frequently, focusing on high proteins, high calorie foods. But also, again, hearing them because, somebody that, pre-diagnosis might not had an issue with, spicy foods or foods that were acidic. But now all of a sudden, you have somebody that gets mouth sores. They eat spaghetti sauce and all of a sudden that becomes an issue. For me, it was chocolate. I couldn't get enough, chocolate because it was soothing in my mouth. But again, it's making sure that we understand it's not just the food security, but also again, sometimes it's just that there's a loss of appetite. Taste changes. They're starting to feel nauseous when they eat sometimes. Fatigue, as Melissa, has stated several times. And they also could have difficulty swallowing, depending, of course, on what their diagnosis is, especially, head and neck. So again, I think, when we're addressing food security and what I've learned is that, kind of staying open to understanding that, we do need that nutrition. We need to incorporate, fresh fruits and vegetables, into our diets. We need to look at, strategies that is going to make, eating something that's going to be pleasant versus non-pleasant. Because again, is the only way that we're going to continue with our strength is if we're getting that nutrition. But also again, understanding, do I need to have Boost? Do I need to have some Ensure protein bars? Those type of things kind of, educating individuals with that as well to help them with their nutrition.
Thank you for that. Nutrition is definitely key in here. Colleen, do you have any thoughts related to that?
Yeah, I love it. Every single symptom that Kathy mentioned is one of those nutrition impact symptoms for sure. And that's why we have to be able to address those. And I do think there's great opportunities to move forward in this space. I think recall that I said that less than 5% of people truly meet the dietary guidelines. So I think we should move away from food insecurity screening and provide services to everyone who need it. And we know that 50% of people, of the 50% of cancer centers that actually screen with the validated tool for malnutrition in the country, 35% of those don't use a validated tool. So I'm giving you statistics about 50% of people walk in the door with some form of malnutrition at diagnosis. To me, that is irregardless of their financial status, their race, their ethnicity. I think every single person who walks in should have validated malnutrition screening in a hospital system. And then we would get everybody, almost everybody, into some kind of nutrition services. And I think that is the ideal situation. And for the first time in my life, I can say it might actually come to fruition finally, because of the work people even on this panel are doing and collecting the evidence and speaking out about these things and saying it's making a difference in the lives of people and in their caregivers and their families. I mean, in the chaos of cancer, nutrition is what we need people to be able to control, right? And get access to, and they can do something for themselves and their caregivers if they can help to provide good nutrition and they feel good about that. They're like, I can do something for my person, right? So it's a beautiful thing. But thank you everyone for your awesome comments on that.
I love your vision of like, let's just make it available to everybody, right? I do have a question in the chat, and I don't know if this is for you, Colleen, specifically around the impacts of sugar intake and cancer on our health. Does excess sugar intake affects cancer cells in any way? And is there any direct correlation? I don't know if you are able to answer that or somebody else within the panel.
Well, that's certainly in the top 5. I get asked every time I'm on a panel, and for good reason, because we have misinformation out there. I will tell you that the American Cancer Society addressed sugar in those guidelines that I mentioned, and I would encourage everyone, because that has the references that I won't be able to recall and cite. But I will tell you, the whole deal with sugar has sort of got blown out of proportion in terms of the soy, but we'll stick with sugar for this. The sugar is more related to the increase in calories that promote obesity, overweight and obesity that drive cancer. Yes, cancer cells use energy to grow. All the cells in our body need nutrition, they need oxygen, and they need elimination of waste. Those are the three things that keep every cell in our body alive. So the thought that we're going to remove all the added sugar, which is one of the recommendations to decrease added sugars to less than 10% of calories, is a great idea for all of us to remove added sugars. But I absolutely do not advocate for people removing like fresh fruits and vegetables that have sugar, natural sugars, because those also have phytochemicals that we show to fight our cancer fighting in our bodies. So I would say adhere to the dietary guidelines and the recommendations of the ACS, and you will be fine. So your cancer cells to grow will find other mechanisms by which to use for energy. If it's fat or protein or whatever, they will find it. So, but, you know, ease back on the added sugars, and that would be super for all of us. Good question.
Thank you, Colleen. Thanks for sharing that information with everybody and the audience. Let me move a little bit more onto the operational aspects of all of these, right? We talk about the challenges, like the importance of nutrition, what we're doing for screening. But I think we have a lot of people within our audience interested in like, so how can I do this within my clinics, right? So maybe I'm going to start with you, Melissa. Right. So how can we partner with community organizations out there to address this issue?
Yeah, I mean, that is a great question. The first thing I'll say is, as you've probably heard throughout this conversation, is you got to find a great partner. And you know, I am not in the business of food. That is not my background. I am a project manager, a grant writer, you know, former educator. And so, but I had to find someone who was in the business of food and understood how to set up a food pantry and how to do home delivered meals and all those kind of things. But I also will say this: you have to get buy-in, and you have to get a team around you. And I'm not just talking about you know, the APPs that brought this to me and the oncologists. I'm talking about everyone. The nurses, the MAs, the practice manager, the director, the vice president, they have to all endorse and support this project, because you're going to, at different times, you're going to hit barriers. I remember coming in one day to the pantry, and there were a bunch of like architects there looking at the space. And I said, what's going on? This is where our pantry is. We feed, you know, hundreds of patients, and immediately the practice manager, the director, you can't touch that space. You can't move anything. And I think that that's important. The PSRs, I mean, they know who gets the food. And if I can give any advice, is the KISS principle. Keep it simple, right? And so, you know, getting the food out to the PSR knows who's getting the food. They understand it. And they will give it to the patient. It's a one-stop shop. They're coming for their appointment and they're getting their food. And I think that's a beautiful thing, because they are tired and they don't feel like grocery shopping, and they know they're getting this food, and they really appreciate it. I had a patient the other day that sent an email and went through every single product, every single item in the bag, and explained how it was helpful to her. So if there's a question about whether the patients use and appreciate it, I can say they absolutely do. But that buy-in from people around you is so important. Everybody has to buy into this.
Absolutely. So buying in and finding the right partner, which it sounds, Kathy, you were the right partner for Melissa. So I'm gonna ask you this next question, right? Which is around the current landscape. I think we've all heard like there are some cuts specifically around food throughout, right? So there's like some potential funding challenges already underway and ahead. So curious as to how you are overcoming some of those challenges.
Great question. As an organization, you know, that's probably facing, you know, anywhere from a $3 to $6 million loss, depending, of course, on the day, whatever of the week. But, you know, as Melissa said, it's really kind of partnering with an organization and having a belief in what we do. You know, our mission, of course, is helping individuals that, of course, are in need. And, this for us was something that works. I want also everyone, to know as far as our program goes, we are providing the meals directly to the client's home as far as our Meals on Wheels, but it's a hot meal as well as a hot lunch as well as a cold supper. So, many of our patients, it's not even a question of being fatigued, but also again, they might not even have the capability to stand at an oven, stand at a stove, prepare the meal itself, warm it up. We're having all that. And then also, again, that wellness check. If a client is not home and does not answer the door, we call their caregiver. If the caregiver says, my loved one should be home, then we need to call in a wellness check and get the authorities involved. By all means, we do. We also offer our clients an opportunity to get free pet food, whether if they have a dog or a cat, because so many times, if individuals can't get themselves to a store, they don't have the financial means to, they're giving their own food to their animals. The animals, of course, are a companion for them. It's their comfort. So, we're able to provide dog or cat food, to the clients when they're on service with us. We also celebrate their milestone, whether it's a birthday. So again, sometimes, we're trying to uplift them because some of these patients, we're the only, that volunteer could be the only one that they actually see that day because not everybody has a care support system. I'm hearing, about the patient and kind of that the patient does so much and then all of a sudden, the caregiver might not have been doing things. I was the one that does everything in my household, and I felt as long, I struggled hard to try to keep that going because for me, it was a mental thing. You talk about mental health, I felt as if I couldn't prepare food for myself, am I letting somebody down or I'm not strong enough? But then, when I realized that I needed to rely on Jack and who is he'll tell you he's the caregiver of the year, but when I had to rely on him, my mental health, of course, changed. But again, being able to provide this service and we're doing everything that we can to advocate. With, we have a wonderful government affairs team that, is walking the steps in Washington and, trying to get to our local congressmen and senators, et cetera, to help, offset some of the burden that is out there with the high of cost of food. And then, of course, our development and fundraising team. We're very fortunate that, we have wonderful grant writers ourselves, as well as a strong foundation that, will host event and work to solicit other donors. Again, no one more important than for this project than the American Cancer Society. For Melissa and I, who are survivors, we are so committed to this program because, we know the positive outcome that it's making. And that's what kind of keeps us going.
Thanks for that answer, Kathy. I think if I were to sum up, which you said it so beautifully, but it's like really community coming together
Yep.
To address some of the gaps that may be out there. So I appreciate you sharing your experience in that regard. So maybe this next question is for you, Yules. So what advice would you give to someone wanting to stand up a similar program to what you have? Right? Like, what are some of the challenges? Tell us a little bit about your experience and advice.
Yeah, great question. I was actually just thinking, listening to everybody talk, that I need to make like a worksheet for people who want to start a program like this because there are so many things to consider. So first and foremost, funding is huge. Obviously, food is not free. There are grants available, which can be really helpful. A lot of communities, like ours, we come from a privileged community. So there's the Friends of the Dartmouth Cancer Center who raise a ton of money. There's an annual event that raises this year $10 million for cancer research and support, which is amazing. I also think knowing the networks in your community can be super helpful because it sounds kind of dark to say, But one of the good things about cancer is that it does affect the wealthy as well. So there's money in cancer research, cancer philanthropy. And that's actually one of the reasons that I work in cancer, because it's one of the best fields in terms of having support and funding for people who are going through a really difficult situation. So I would say step one, figure out funding. It doesn't have to be a lot. You can start small, couple $1,000s will do you to get off the ground. Step two, figure out who owns, quote unquote, the project. When we began, it was a social worker, and then it transferred to a part-time dietitian, and then to me as the program manager. If you have people in your clinic who are really passionate about it, or who have maybe somewhat flexible hours, that can be really awesome. And I would also recommend reaching out to other organizations in your community. So our program started as a partnership with a local food pantry, which we outgrew relatively quickly, just like the logistics of that and their ability to get us enough food for our patients. But working with people whose job it is to move food and do it safely and efficiently can be really, really great. So I would recommend, if you don't have in-house expertise on that, reach out to people in your local community who do. Meals on Wheels can also be a great organization to look into, since they know a lot about not only food logistics, but specifically working with older people, working with people who are maybe sick or have logistical problems. So that can be awesome. And then the food logistics are the hardest part, I won't lie. Like, this is an ongoing struggle for us. We have a couple different vendors, all of whom are wholesalers at this point. And some of you guys might have heard one of our vendors, UNFI, got hacked like 3 weeks ago, and their system totally went down. So like every Whole Foods in the country was out of groceries, all the co-ops near us, we couldn't get shelf-stable food. So the food supply chain is really volatile and unpredictable, and will unfortunately only be getting worse as like the economic situation continues to deteriorate over the next few years. So that's the hardest part. If you have local producers, we are fortunate to live in a really rural area of the country. So like we buy our milk from a dairy 10 miles down the road, which is obviously higher quality in many cases and can be cheaper, because so much of the added cost of food is the logistics of the supply chain and all of the middlemen. So if you can buy directly from a producer, that's often the best way to go about it. And to keep that philanthropic money if you have it in your local community. And then the last thing to consider is space. Where are you going to put the food? Is it cold? Is it shelf stable? Commercial refrigeration is insanely expensive. We have a fridge that costs $16,000, and that's like pretty standard for a restaurant grade commercial fridge. So that's a real issue. I saw that Marlo in the chat was wondering about how to do fresh food specifically. And honestly, as we are in this phase of expanding to the other locations of the Dartmouth Cancer Center through Vermont and New Hampshire, with those new locations, we're starting back at square one with shelf-stable food bags, just because refrigeration brings in food safety concerns, significant cost, and additional staffing and certification requirements to keep that safe, basically. So it's really worthwhile if you can do fresh foods. Our most popular items consistently are produce and dairy, because it's the stuff that people cut out of their personal food budgets when they start to struggle financially. And obviously it has really awesome health impacts for people to be eating whole nutrient-dense foods. But yeah, there's a lot of considerations, and also worth saying, I think, that not every program has to look like Healing Harvest. Like, there are other programs across the country that have cancer center food pantries with all different sorts of models. And I think it's up to you and your local knowledge to figure that out. But I'm happy to help. So email me if you have any questions.
Thank you. We appreciate it. I appreciate you offering to help some members of the audience. I can tell you that I've had the privilege to partner with some of our FQACs here in Ohio to support some of their food as medicine programs. And it's definitely a lot of logistical things to consider when implementing something like that. Kristen, I'm wondering if you have any piece of advice from your perspective to people that may be wanting to stand up this type of program.
Yeah, I'm not sure that I can add anything that hasn't been said already, but I'll reiterate the importance of partnerships. So we also, in addition to kind of the screening pilot that we're doing in some Hope Lodges, we do have a program through our Boston Hope Lodge that's in partnership with Community Servings, which is a Boston-based medically tailored meal provider. And this is, going back to Colleen's comments about kind of making food and nutrition assistance available to everyone. This is just really kind of an opt-in. If you're staying at the Hope Lodge, you can sign up for the program. And people get medically tailored meals delivered to them at the Hope Lodge for the time of their stay, not only for that enough for them, but for their caregiver as well. So making sure that kind of everyone's covered. So, and Community Servings, I can't say enough about the kind of Food as Medicine Coalition organizations and what great partners they are. Community Servings has been amazing. I know Colleen's done work with other Food as Medicine Coalitions organizations. So, I think it's really kind of about finding those good partners and kind of how to make it work. I think like Melissa pointed out and Kathy, a health system isn't in the business necessarily of being the food assistance and food logistics experts, but there are community-based organizations or other organizations that are those experts. So kind of figuring out who they are and how to work together. So yeah, I think it's all been said before, but just to reiterate.
Thank you. I appreciate that, Kristen. So we've talked about, the importance of nutrition, how the importance of funding, right? If we wanted to stand up these type of programs in our health systems. I think many people in the audience are probably wondering about sustainability, right? Like we talk about importance of funding. So how do we make this type of program sustainable? And this is a question for anyone who may be willing to answer from our panelists.
I can take a stab at it. I don't want to jinx anything because I've only been doing this for a year. So long-term sustainability is TBD. And we are very privileged to have the Proudy, as I said, which is a huge driver of our fundraising. But I think one of the critical things about long-term funding sustainability is to ensure that you're capturing high quality data from the very beginning of whatever intervention you're going to do. Because the American Cancer Society has pretty stringent data requirements about the number of patients served, their characteristics, and a lot of other funders will want that information as well. So the more hard data you can get on patients is essential, but also being sure as you are kind of working through whatever your intervention, your pilot program, whatever is, keep your eyes peeled for patient stories and patient testimonies, because when you're in a position of writing a grant or meeting with a room full of donors or having a one-on-one conversation with someone who's potentially looking to fund, you should have in your back pocket like 3 or 4 anecdotes that really get at the heart of what you're doing and kind of, I don't want to say tug on the heartstrings and do a little potential emotional manipulation, but like it's a really serious, heavy topic. And I think that the work of doing food security interventions for cancer patients is obviously extremely valuable. Like nobody really needs to be told that this is a good thing to do. But having those illustrative examples, I think can make it really concrete for people in a way that is like potentially impactful in a lifelong way. Like our current director of our cancer center, Dr. Steve Leach, he was at first, I'm told, it was like sort of a sell to get him on board with the idea of expanding the food pantry program. It didn't exist prior to 2021, and it wasn't really on anybody's radar. But now, several years later, after seeing the patient impacts, every time Steve talks about Healing Harvest, he has tears in his eyes at public events. Like having that emotional impact on people in your organization and outside, I think is critical.
Thank you
So
for
I
that,
can
Jules.
add on to that, Jules. That was great information. And I think the main thread we're hearing is find your nutrition champions in this space. And I agree with that. But also for those that haven't started, understand that many of us on this call have been doing this for years, and you can start very small. And I'll give you, 2 examples and then an idea. So again, you can read about things, but I write grants, and my sustainability is the next grant, and hopefully seeding it so that before I leave, that the people, and we have to write a sustainability plan on each grant. But for instance, the Garden of Hope at The Ohio State University I've been involved with them since the inception of 2011. And this is funded by our cancer center every year in their supportive care services called James Care for Life. And we got tired of talking the talk, and we wanted to walk the walk as well. So the cancer center, through our College of Medicine, 4 miles from where they're treated for cancer often, at the James, they can come out 2 to 3 times a week for 2 to 3 years in a row and harvest fresh, free produce at our gardens for, the entire season, which runs from typically the beginning of June to the end of October. And we have dietetic students and dietitians, and we're doing garden side demos on the whole thing. It's a great model that is funded by the Cancer Center as part of the Cancer Center. And it just every year happens, and it's a beautiful thing. It started very small. And I was able to do some research off of that. We also connected with our local food bank, and we have something called the food pharmacy, where our primary care physicians, and these are national. So I'm saying you can find models that would work for you. So I would encourage people to go out and see all these and what people are doing. There's other hospitals with rooftop gardens now. I mean, it's out there and it's fantastic. So find what would work and find your champions. And then if you really want to get into paying for big time nutrition services, which I think we all should, there's the Medicaid 1115 waivers that I think are important. I believe a few weeks ago, 11 states, and you can look it up on the Waiver Watch, 115 Waiver Watch, have waivers that are specific to nutrition services broadly. And those do cover food as medicine programs that ship food to people's homes or allow for paying for food pantry things or whatever it is. So you can look at, and there's 7 more, I believe, pending. I'm from Ohio. Ohio doesn't currently have explicitly a waiver right now that it covers food as medicine or nutrition services. We have one for substance use disorder, but there's things we can do. There's people in Ohio talking about bundled payments, for instance, to cover it. You can also add on to an existing waiver, which is probably the quickest thing to do, or you can get with your public health people and who want to talk about waivers, 5-year champions, and you actually could write a waiver and get a waiver. And that's a beautiful thing because it pays. And I see they put the link for you in there. So I'll stop there because I know there's other people on the call whose states have waivers and how they're using them. We do not, unfortunately, but we're garnering the evidence now very actively to try to submit for one.
Here at Feedmore, we actually do have a food pharmacy as well. So we actually have not only do we provide the nutrition counseling and education, but also have a food pantry that is not only open to, let's say, students in the university that we partnered with, but also for the community members, which happens to be very closely in proximity to the different medical campuses that are around Buffalo. So we have individuals, whether it's their caregiver, et cetera, there's no income that is asked, no qualifications, nothing. They can just come in. And then, of course, we try to, provide all the different, food groups that, of course, would make up a good diet as well. So, and again, I think that people need to be, I think Jules kind of touched base on it a little bit as well, that cancer doesn't discriminate, and it doesn't take a day off. It's not as a common cold where, you know, in 2, 3 days, you're going to start to feel better. Your diagnosis, you know, kind of stays with you for a period of time. And it's not only just going through the treatment, but how is your body going to react after the treatment? And then you kind of go into that survivorship mode. So it's really kind of staying in tune to an individual. And I strongly, we recommend, tailoring, somebody's dietary needs to an individual. And it really should be more of an individual process than, deciding, this is for everybody. So depending on who they are. So I just wanted to add that also.
Thank you. I appreciate that. So it sounds that it's extremely important as people are looking to stand up this type of program, to find something that fits them, right? That there's a lot of resources out there, the importance of patient stories for sustainability and to be able to communicate the impact on these. I love what you said, Colleen, like nutrition champions, and something really key, I think, for anything, not just for grant writing or any potential 1115 waivers or in lieu of services, it's data, data that really speaks about the impact. So I'm also here in Ohio. I will share that the 7 Medicaid managed care organizations here in Ohio, what we are not looking for an 1115 waiver on food, we are looking at in lieu of services, which is a mechanism to allow to pay for food here in Ohio. As a potential. That's something that we know that it's important for the Medicaid members here in the state. So you've likely heard a little bit more about that over the next few months. So I think we're like getting close to time. So I really appreciate like all of the insight and input from all of our panelists. But I want to wrap it up with one last question for everyone, which is looking ahead, what is one change, big or small, you hope to see in how we support cancer survivors facing food insecurity? And let me start with you, Melissa.
I think, it's kind of been addressed a little bit, but identification of patients. I think that, and I know everyone uses different tools, and there's, it's like with any measure and any scale, right? There's, people will have opinions, but I think identifying people and also identifying the right people at the right time, because our patients will meet with the nurse navigators and they'll say, we're fine. And this is after their second appointment. We're fine. We're great. And then I will maybe round at infusion, or I'll see them at our WIG program, and they are not fine because they have never had chemo. And this is their first experience with what it's like to be in, multiple rounds of chemo and these drugs and the effects. So I think that the timing of identification is an issue, because, if we say, well, let's just screen people initially, a lot of patients are going to respond with, I'm great. So I think one change is maybe like longitudinal kinds of assessments, right? It's not just a one-off when they're diagnosed and their first treatment, but it is 12 weeks in, or 6 months in, to circle back, whether it's the social worker or the navigators, and say, how are you doing? And have your food or nutrition needs changed. And so that's a change I'd like to see, that I'm kind of advocating for within my own team. And I think it could help capture, right, more patients that are having issues with food.
Great. Identification then. What about you, Kathy?
Great question. I think I would agree, with Melissa. Just again, nobody wakes up and says, I want to have cancer. But when you do, it's so warming, and this has been so uplifting that, today there are resources for those that, when they are faced with a cancer diagnosis, of so many opportunities out there to be able to provide that hope to not only the cancer patient, but the caregiver and their families. So again, just many thanks. And I'm
Mhm.
so fortunate and blessed that I've been asked to be a part of this today and to be able to share, the work that Melissa and I are doing together and to hear the great work that everybody else is doing and the things that I've learned. So thank you.
Thank you, Kathy. So if we can identify, we can help people. So, Kristen, what about you? Any change, big or small?
Yeah, I'm gonna go big picture and say that the change I would love to ultimately see is that food and nutrition are really like standard of care in cancer care, and they're paid for by public and private insurance. Everyone's doing amazing work, getting funding through philanthropy and other ways, but ultimately, this should be it's important enough to be something that is available to everyone across the board.
Agreed. What about you, Colleen?
Yeah, so I'm going to say two rolling off each other. The first is that we figure out a way to get everyone from pre-birth and beyond to be adhering to what we know the evidence-based guidelines are for behaviors, and including nutrition and stress and sleep and exercise, so that we can prevent cancer in the first place and the 80% of chronic diseases that are diet related in the first place. I'd love that. But until such time, I agree with Kristen that we need to find a way to fully integrate nutrition and other supportive care services into cancer care as standard care. So those are my big picture. I would love to. I love my job because I love our patients, but I'd rather not have cancer and open a flower shop or something like that.
Thank you, Colleen, for that. I know we're out of time almost, but Jules, final words on your end.
Yeah, I would say, kind of piggybacking off of Colleen and Kristen, my dream would be to have food security interventions physically on campus at every cancer center in America. And I know that I may have been a little intimidating earlier by talking about the logistical challenges of like the cold chain and storage and all of that stuff. But what I try to remember when things are going wrong for us is like, American hospitals can give people organ transplants. Like, we have the logistics and the ability through working together and really putting our heads together to solve a problem to cure many kinds of cancer. Like, things that we thought were impossible to do even 40 years ago are now sort of the norm in American medicine. So I think that once people understand that food interventions are, in many cases, as life-saving as organ transplants and CAR T and these other kinds of therapies, I think we can figure out how to do it, Just get a pallet jack, get a walk-in cooler. It's really not rocket science. So that would be my dream.
Thank you for sharing your dream with us. And I want to thank each of you for taking the time to share your expertise and your knowledge as it relates to this topic. I see Lindsay on the screen, which is probably time for us to wrap it up. So, Lindsay, take it away.
Yes, gosh, thank you all so much. Pallet jacks for everyone. Let's figure this out. I think one of the things I loved hearing about, especially from such an incredible group of women, is just trying to solve problems with such practical, logistical answers and the passion behind it. So thank you for all you guys are doing and for being here today. So many valuable takeaways from that conversation. As we wrap up today, we wanted to share one a new resource that the American Cancer Society has launched. Cancer Risk 360 is a fast, personalized risk assessment tool developed by ACS to empower individuals with actionable insights. In just about 5 minutes, users receive a tailored snapshot of their cancer risk based on their lifestyle, their family history, screening behaviors, and it's really designed to spark informed conversations between individuals and their healthcare providers. It helps promote early detection and hopefully guides people towards healthier choices. So we encourage you to check that out. No matter where you're coming from, a health system, a navigator, a community partner, Risk 360 will really help meet people where they are. So please visit our website at acscancerrisk360.cancer.org. And we'll make sure this slide will be in the presentation so you can check it out too. We hope you'll join us for our remaining 2025 virtual forum sessions. In September, we're going to be discussing current issues navigating immunotherapy, and in November, we're going to focus on rural health. 2 CMEs will be available for each of those live sessions. We are also pleased to share that this program and all of our previous programs are on YouTube. You can't get the CMEs through viewing on YouTube, but please share this program with your colleagues or someone you think could gain insight from the conversations that happened today. The CME certificate will be sent out in 2 weeks to those who have completed the post-event survey. The survey is going to pop up at the close of today's session. You will also receive a post-event email in 24 hours with the recording of the session and the survey link in case you missed it this morning. We thank you again for joining us today and for your commitment to fight for a world without cancer. Thank you so much.